Thank you everybody for taking the time this evening to join us. We're so glad that you're all here. Dr. Barbalat has an awesome presentation for you guys, so thank you for joining. I'll introduce myself. My name's Jyoti Nanda. I am the Sales and Marketing Manager here at Utiva, and I also have my colleagues here, Faraz Nomani, who's a co-founder, as well as Derek O, who is the other co-founder. And just before I move into introducing Dr. Barbalat, I wanted to quickly go over some housekeeping. So Derek has mentioned for Q&A, just be sure to type in your questions throughout the presentation. There's no need to wait till the end. We'll be organizing them all, and then we'll go through as many as we can. And then in terms of our agenda, we're planning to run until 8:30. So we are going to spend about 30 minutes, 30 to 40 minutes with Dr. Barbalat's presentation, and then the remainder of the time will be for the Q&A. I just want to remind everybody that we do have a raffle. So at the end, we'll spend a couple minutes to go through the raffle, and then we'll hang on. The Utiva team will hang on at the end. If anybody is interested in learning more, we'll spend just a couple minutes on giving you guys some more information on our products. Okay, and with that, I will introduce Dr. Yana Barbalat. Dr. Barbalat, thank you so much for joining us today. Just a brief intro for Dr. Barbalat. Dr. Barbalat is a urologist. She completed her medical school and residency training in urologic surgery at Rutgers Medical School and a fellowship training in voiding dysfunction and female pelvic medicine at Columbia University Medical Center. She is currently in practice in Massachusetts and specializes in recurrent urinary tract infections, overactive bladder, pelvic floor dysfunction, and incontinence. Thank you, Dr. Barbalat, and I will pass it over to you.
Cool. All right. Thank you so much. And thank you for having me. I love doing this talk because I find that this is just so, UTIs are so common in, everyone's practice, whether you're a urologist or a family doctor, you see it a lot. And so I feel like we need to talk about this stuff more. So speaking of that, the interesting thing is that it was not until 2019 that basically the American Urological Association and the Canadian Urological Association came out with guidelines for prevention of recurrent urinary tract infections. So there were guidelines for all kinds of things, for prostate cancer, for kidney stones, for kidney cancer, for all kinds of issues, but no guidelines by the Urological Associations, America, Canada, to talk about recurrent urinary tract infections. So thank God now we have guidelines, and I am going to talk about some of those guidelines today and also talk about my practice, specifically what I do in my practice and how I manage my patients. So, today I wanted to start with a case report, and this is a true case report. A lady came in to see me, this was about a year ago, who had, no, actually, it was probably about 3 years ago now that I've seen her. So she was a 70-year-old female. She had recurrent UTIs for about 3 years, 4 to 5 infections a year. She was treated with multiple courses of antibiotics. Every time she had a UTI, it was a culture positive E. coli infection. And finally, she ended up basically with C. diff colitis after one of her antibiotic courses. It took her a while to recover from C. diff colitis. She ended up having a fecal transplant, and then she was basically referred to see me to see if there's anything that can be done to basically prevent her infections. And so that's when I saw this lady. And so we'll come back to her throughout this presentation. So what are recurrent UTIs? So recurrent UTIs are 2 or more infections in a 6-month time period, or 3 or more infections in a 12-month time period. And so you can basically have 2 types of recurrent infections. You can have reinfection, which is a new event. It's a reintroduction of new bacteria into the urinary tract, and a new infection. Or you can have persistent UTIs. So basically UTIs that are caused by the same bacteria from a focus of infection. So the bacteria that basically was never treated. And so majority of recurrent UTIs are reinfections. But sometimes you do see persistent UTIs. For example, in patients that have large kidney stones, they can harbor bacteria, and that bacteria can basically recurrently reinfect the urine. So what are the risk factors for recurring UTIs? Well, there are quite a few actually. So first one is reduced urinary flow. So men with BPH and large prostates, prolapse. So, bladder prolapse, pooling of urine in that sort of prolapse bladder can cause UTIs. Strictures in the urethra, inadequate fluid intake leads to less urination. Less urination means urine hangs around the bladder for longer and can get infected. There are also factors that promote colonization. So reduced estrogen states, spermicide use, sexual activity, with just the transfer of bacteria that happens with sexual activity, and antimicrobial agents. Most of these things, the reduced estrogen, spermicide use, and antimicrobial agents change sort of the microbiome of the vagina, and they change the composition of what's going on in that area, and that causes a patient to be predisposed at that point to an infection. And then finally, factors that facilitate ascent of bacteria. So catheters, incontinence, stents. So things like that promote bacteria from, colonization and adherence and ascent into the urinary tract. So what is my workup for patients? So first I get a good history. I find out how many infections the patient has. What are the culture results? Are they true infections? I ask about patient symptoms, and then I ask about associated risk factors. This is really the most important part, really, of the entire history. So are they using spermicides? Are they using baby wipes and just over cleaning the area or throwing off the pH of the vagina? Sexual activity, birth control use. Do they have incontinence? Do they have constipation? And are there any associated urinary symptoms that would suggest problems with urination and basically a holdup of urine? And then I talk to patients about their fluid intake, how much they're drinking and what they're drinking. Then I do a physical exam. My physical exam is generally pretty brief, actually. I check for, again, anything that can predispose a patient to infection. So urethral diverticulum can cause persistent infections, prolapse of the bladder, and then I look at the vaginal epithelium to look for atrophy and evidence of reduced estrogen state. And then in men, the important thing here is a rectal exam to check the size of the prostate. Does this patient have an enlarged prostate or not? Again, suggesting reduced urinary flow. And then it's very important as a urologist to get a PVR, which is a post-void residual, to see if the patient is retaining any urine, because these infections, if a patient has urinary retention, these infections are more difficult to treat and they are more likely to recur. Next thing is urine analysis, urine culture. You basically want a clean catch midstream specimen. That's ideal. And you send it for urine culture. Now, sometimes the urine culture will come back contaminated, but the patient has symptoms. So in that case, what I do is I actually have the patient come in and I get a catheterized sample from the patient. Now, this is actually very interesting. Traditionally, we have used a 10 to the 5th colony forming units as a diagnostic cutoff for a UTI. But recently, there was a study done that was actually published in New England Journal of Medicine, which was a very interesting study that basically showed that in symptomatic women that are growing at least 10 to the 2nd, so only 100 colony forming units of a single gram negative, it has to be a gram negative uropathogen, is actually that's probably a more appropriate cutoff for patients that you think have an infection. So all you need really is only 100 colony forming units to diagnose a UTI in a clean catch specimen where there's only 1 single gram negative organism growing. Now, this is interesting because a lot of labs will not actually report that low of colony counts. And so if they don't report that low of colony counts, those patients may have that, where it says no growth, you're sure the patient has a UTI, their UA is super positive, but then the culture comes back no growth. So it is really important to know the lab criteria that your lab is using and if they're actually reporting very low colony counts or not. And this is actually where UA is helpful. And I definitely look at the UA, especially how many white cells are in the UA. Now, what about cystoscopy and imaging? I feel like this is probably the reason why most patients get sent to a urologist because the primary wants to know, hey, should this patient have a cystoscopy? Is there something that we're missing? So the guidelines actually say that the use of cystoscopy and renal ultrasound is not routinely recommended for workup in an uncomplicated recurrent UTI case. Now, upper tract imaging does tend to be super low yield. I will tell you that. But I still get renal ultrasounds pretty much on anybody that comes in with a recurrent UTI because I would hate to miss a kidney stone, a large kidney stone that is basically harboring all this bacteria, or a bladder stone that's harboring bacteria. So ultrasounds are easy to get, they're risk-free. So I get an ultrasound on pretty much everybody. And multiple studies have shown that the yield of cystoscopy is very, very low, especially if you have negative imaging. So I rarely get cystoscopies on my patients. Now, let's go back to the patient. So what was my workup for this 70-year-old lady with recurrent UTIs? Well, first of all, again, I try to find any modifiable lifestyle risk factors in this patient. What is her hydration like? Is she sexually active? Is she constipated? How is she wiping front to back to front? How is she wiping? She did not have any, past medical history for me. On physical exam, she did have a little bit of vaginal atrophy. She had no prolapse. Bladder scan did not show any significant post-void residual. On the urine analysis, there was no microscopic hematuria, and renal ultrasound was normal. Now, in this patient, a cystoscopy is not indicated. Now, when do I get a cystoscopy? I get a cystoscopy if the patient had any blood in the urine, gross hematuria, any blood that they saw in the urine. I get a cystoscopy if there's microscopic hematuria without an infection present. And I also tend to get cystoscopies if the patient has a history of pelvic surgery, mesh placement, really any pelvic surgery, because who knows, maybe there's a suture in the bladder with a little stone attached or mesh in the bladder. So I do cystoscopies when, I just want to, again, rule out any nidus for infection in the bladder. Now, going back to the guidelines, how to prevent recurrent UTI. So first, I talk to patients about behavioral modifications. So you want to reduce and minimize those risk factors. So first, you want to ask about sexual practices. Avoid spermicide use. Spermicide can alter the pH of the vagina. It alters the microbiome of the vagina. So you want to avoid spermicide use. You want to avoid anal to vaginal sex, okay? And I tell my patients to pee before sex and after sexual activity. And the other thing I tell my patients is to drink water after sexual activity, because I want them to get up one extra time in the middle of the night and urinate and empty their bladder one more time. Now, this is actually in our guidelines, effective increased water intake on prevention of UTIs. So there was actually a randomized clinical trial that took premenopausal women with recurrent UTIs who were drinking less than 1.5 liters of fluid a day. On average, it was about 1.1 liters of fluid that these patients were drinking. And they added 1.5 liters of daily water intake to a group of patients. And the other group, they did not add any water intake. And they basically did show that patients that drank more water in the increased hydration group, they had less UTIs per year than the group that was not drinking any water. So this was a randomized clinical trial. And so our guidelines do mention this as a legitimate recommendation for patients that have recurrent urinary tract infections. So increasing hydration is important. Now, the other thing that our guidelines talk about, and this is also huge because this is new, is that clinicians can offer cranberry prophylaxis for women with recurrent urinary tract infections. And this is non-antibiotic prophylaxis, which is really, really nice. Now, let's talk about this more. Let's talk about cranberry. So cranberries contain PACs, okay? And PACs are basically organic compounds that prevent the adhesion of bacteria to the urothelium, okay? Now, previously, even when I was in residency, basically in in 2010, we did not recommend cranberry for UTI prevention. And the reason is because at that time, the trial results that we had for cranberry were discordant. There was no standardization of dosing. They basically did trials with cranberry pills that had a very low dose of PACs in them. And so there was no consensus on whether or not cranberry was helpful in UTI prevention. But the thing that happened was recently cranberries have been a subject actually of a lot of good trials, a lot of randomized clinical trials, controlled trials, blinded trials, and we have much, much better data. And so we have at least 6 randomized clinical trials that compare cranberry to placebo, and 2 comparing daily prophylaxis, antibiotic prophylaxis to cranberry. So we have much, much better trials now, and these trials look very promising and very good and favorable for cranberry. So basically, the cranberry studies that we have test capsules, beverages, or powdered form, and they use standardized dosing. And the standardized dosing that is used is 36 milligrams of PACs. So that is basically the dose that has been shown to have enough anti-adhesion activity versus bacteria. And so the American Urological Association, Canadian Urological Association did a pooled analysis of 6 randomized clinical trials that looked at cranberry versus placebo. And cranberry showed basically a reduction of UTI incidence by about 37%, so a third less UTIs. Okay, there was also no significant difference between daily cranberry versus antibiotics in the risk of experiencing 1 or more UTIs at 6 or 12 months in 2 trials. So that is huge because patients now don't really need to take antibiotics. They could maybe perhaps take cranberry in order to prevent their infections. So this was basically the biggest trial that was done on cranberry. There were 373 subjects. This was a multi-centered, double-blind, randomized controlled study that was done in 2016, a very good study that basically they gave patients either 240 mLs of cranberry juice per day containing 41 milligrams of PACs, or they gave patients fluid that tasted and smelled and looked like cranberry juice. And cranberry juice did reduce the incidence of UTIs by 31% over 24 months in the patients that got the juice. This was another study that basically looked at trimethoprim. And this was a study in older patients, women who were 45 and older, randomized trial in 137 women that looked at either cranberry, 500 milligram capsule of cranberry containing 36 milligrams of PACs, versus TMP, 100 milligrams daily for 6 months, and there was no difference in the UTI rate or the time to first UTI. So again, showing that cranberry can really be helpful in patients with recurrent UTIs, and again, using that standardized dosing, not just like 1 milligram of PACs, or 2 milligrams of PACs, as a lot of these products contain. Now, what about methenamine? So methenamine is also a compound that's basically converted to formaldehyde and ammonia in an acidic environment. And it requires a urinary pH that is acidic. So you have to give methenamine to patients with vitamin C. There's very limited side effects of methenamine. There's no resistance that we know of. The problem with it is sometimes it can precipitate with sulfonamide. So you don't want to give them at the same time. But the Cochrane review in 2012 basically said, all the studies on methenamine, at least most of them, are kind of poor quality studies. Only 2 out of the 13 studies actually used urinary acidification in the study. So they made sure that patients' urines were actually properly acidified and methenamine was used properly. There was also a variety of doses used. There was not even a standard definition really for UTI in most of these studies. And so the conclusion is methenamine may be effective in patients that do not have any GU abnormality. But this was in 2012. Again, now March 2022, there was just a recent study that was just published comparing methenamine to trimethoprim prophylaxis for 6 months. And this was a randomized trial, and there was no difference in UTI recurrence. So again, this is another option to physicians. This is a twice-a-day dosing, so I don't love using methenamine. And again, the data on it is not so strong as Cranberry, but this is another sort of tool in the toolbox that now we can use, or at least consider using, instead of using daily antibiotics for patients with recurrent UTIs. Now, what about D-Mannose? D-Mannose is actually very, very promising as well. So D-Mannose is a sugar that binds to type 1 pili and E. coli and possibly other bacteria as well, actually. And it also prevents adhesion of the bacteria to the urothelium. And there was actually a systemic review published in the American Journal of OBGYN in 2020, so recently, that basically concluded that D-Mannose appears protective in women with recurrent UTIs and possibly similar efficacy even to antibiotic prophylaxis. And there was one really good study that was published where they took patients, they put them on either 50 milligrams of nitrofurantoin daily or 2 grams of D-Mannose daily or placebo for 6 months. And the funny thing is that the incidence of UTIs was actually the lowest in the D-Mannose group. It was lower than the macrobid group and lower than the placebo group. So that was a randomized clinical trial. And I think there's going to be more data coming out on D-Mannose. And so, that's one of those things we have to stay tuned for, but this is a very promising way to prevent recurrent UTIs. Now, this is not in our guidelines. D-Mannose methenamine is not in the AUA or the CUA guidelines. Only Cranberry is in those guidelines, but these are sort of also options for the patients that patients can consider, other than using daily antibiotics. Now, what about estrogen? Estrogen did make it into our guidelines. So for peri and postmenopausal women with recurrent UTIs, clinicians should recommend vaginal estrogen therapy to reduce the risk of future UTIs, and as long as there's no contraindication. And this is in our guidelines. It's a grade B recommendation. So let's talk about estrogen. So vaginal estrogen basically increases the production of glycogen by the vaginal epithelium. And so what happens is there's a decrease of the vaginal pH. There's a restoration of vaginal flora. So lactobacillus basically needs that glycogen. And so the more glycogen, the more lactobacillus, and the more lactobacillus, the less pH of the vagina. And so basically vaginal estrogen helps to restore the microbiome of the vagina and make the tissue healthier. And there's multiple different ways to apply vaginal estrogen. There are creams, there are suppositories, there are tablets, there's a ring that you could put in for 3 months and forget about it. And as far as side effects, there could be some local irritation from the cream that women sometimes report, a little bit of burning. And some women also report some breast tenderness when they just start vaginal estrogen use. But there are actually multiple studies that basically show that vaginal estrogen is very effective in UTI prevention in peri and postmenopausal women. There was a Cochrane review in 2008, which showed that vaginal estrogen is safe and effective, not oral estrogen. Oral is ineffective for UTI prevention, but vaginal is safe and effective. And there's really no difference in efficacy between the different application methods. So you can do the cream or the suppository, whichever one the patient basically prefers. Now, there is really minimal systemic absorption. Studies basically have shown that the systemic levels of estradiol versus placebo are no different in patients that use vaginal estrogen versus those who do not. And I tell that to my patients all the time because it's hard to convince patients sometimes to use vaginal estrogen. So you have to tell them that, there's really no absorption of this estrogen into your body. And there's really no evidence that vaginal estrogen cream increases the likelihood of recurrence or progression of breast cancer in women that have a history of breast cancer. But if they do, I always check, obviously, with the oncologist prior to prescribing it. And most oncologists are usually okay with it. Now, daily antibiotic prophylaxis. This really is my last resort. And I would have to say that out of every 100 patients that see me for recurrent UTIs, I probably end up putting like 5 patients, maybe less, maybe 3 patients on daily antibiotic prophylaxis because the other things work. Everything else I talked about today really, really works. So I don't need to go there. Now, this is really an option with the most adverse events: candidiasis, GI side effects, skin rashes, pulmonary, hepatic toxicity, resistance, and nitrofurantoin should be avoided in patients with a GFR of 30. Just kind of wanted to throw it out there as a reminder because it can build up in the system and cause more toxicity. And then the other thing is the studies show that once the antibiotic prophylaxis is stopped, the UTIs basically come back, they recur. So I don't love this method at all. And when patients come in to see me, new patients that are currently on daily antibiotic prophylaxis, I tend to take them off and kind of start over. Now, what are the options? I just listed the different options for daily antibiotic prophylaxis. The other thing you can do is you can also do just postcoital. If patients' infections are associated with sexual activity, then I tell them, okay, well, you can take an antibiotic after sex so that you're not taking it every day. But to be honest, usually I will start with telling that patient to take a cranberry pill after sex. So take a cranberry pill either right after or right before sexual intercourse, and let's see if that works first. And that works for a lot of patients. And if that doesn't work, then I'll tell the patients to take an antibiotic if their UTIs are just solely associated with sexual activity. Now, what do I do in my practice? Just sort of a summary of kind of everything. Patients come in to see me with recurrent UTIs. I get a UA, I get a urine culture, I get an ultrasound. I check their post-void residual to make sure that they're emptying well. I check them for prolapse or any very obvious abnormalities on physical exam. I go over healthy bladder habits. So hydration, no spermicides, no douching, avoid thongs if possible. Again, just increase of transfer bacteria. Void and drink after sexual activity, and wipe front to back. And then I start pretty much everybody on a good cranberry pill. And occasionally, if women have a lot of atrophy, I will start them on vaginal estrogen right away. A lot of people aren't really into that. So patients aren't into starting like everything right away, and they kind of like the natural approach first. So a lot of times what I'll do is I'll start them on the cranberry pill. And then if they come back in 3 months, because I see everybody in 3 months and they're still having infections, then I'll add in the vaginal estrogen if it's indicated. So I see patients at 3 months, at 6 months, and then at 12 months. And at 12 months, if they have not had a recurrence, at a year, I basically tell them they have graduated, and I'll just see them every year. Now, some patients will continue to have infections. And so then I add on other options. So I'll do the 2 grams of D-Mannose daily because I think, the data on that is good. And then if they're still having infections, then I may try the methenamine with the vitamin C twice a day. And then if they're still having infections, then we start talking about maybe doing a probiotic daily, but the data on that is mixed. And so that's sort of my protocol for my patients. And now for this lady, I basically started her on Utiva daily, which is my go-to cranberry pill. I talked to her about, why, about the fact that different cranberry pills are different, and then that you have to have a good cranberry pill if you're going to use cranberry, and you have to have a pill that contains at least 36 milligrams of soluble Pax. we talked about vaginal estrogen use, but she wanted to hold off to see how she does with just a cranberry pill. And then, so I saw her at 3 months, and then I saw her 6 months and 12 months, as I do all of my patients, and she has not had a recurrence of UTIs. So now I only see her once a year. And like I said, I think I first saw her about 3 years ago, and she really hasn't had any recurrences at all. And she's been doing great. So that was my patient. Now, the question is, why am I here, right? Speaking of Utiva, why am I doing this? Well, because basically, as I said, it's really important to have a good cranberry pill. And you want to have a cranberry pill that has 36 milligrams of PAX in it. The majority of cranberry pills on the market do not have 36 milligrams of PAX. So it will say that there's 1,000 milligrams of cranberry or 2,000 milligrams of cranberry, and patients come in thinking they're getting all this good cranberry. But in reality, they have like either 1 milligram of PAX or 2 milligrams of PAX. They have very little bit of the actual active compound of cranberry that you need. Now, we have a way of measuring PAX. And there is actually a group in Rutgers that has done lots and lots of studies on cranberry and cranberry in an anti-adhesion activity in bacteria. And they quantified the amount of PAX in different products. And as you guys can see here, the majority of these products have either too low to measure PAX, or they have like 5 milligrams of PAX. And Utiva really does have a lot of PAX, and it has a lot of anti-adhesion activity by using this supplement. Now, the other thing is, even if you have 36 milligrams of PAX, not all PAX are sort of created equal. So you want to have soluble PAX, because the insoluble, like PAX that come from stems and leaves and seeds, they don't actually have as much anti-adhesion activity. So you want to have the PAX that come from the cranberry juice. And so this was a little study, again, by the Rutgers group that looked at Utiva that had a lot of anti-adhesion activity versus bacteria. And they looked at 2 other brands containing 36 milligrams of PAX, and they did not have as much anti-adhesion activity. And then they looked at, other pills that had basically no effect on bacteria at all, even though they claim to have, a lot of cranberry in it. So that's why I talk through Utiva, because I've been using Utiva now for 7, 8 years that I've been in practice, and my patients do really well. I see it. I see that they do really, really well using the supplement, and they feel like I have some sort of magical cure for them. And it's really no magic, because anybody can recommend, the use of cranberry, the use of Utiva for patients. So. And then this is just a slide with other things. So if you go on the website for Utiva, they also have probiotic there. They also have the D-Mannose, and then they have the cranberry PAX, and then they have UTI test strips. So you can get like, different things all in one site. So just wanted to sort of mention, or show you guys this slide as well. So that's it. Thank you.
Thank you, Dr. Barbalat. That was a great presentation. We
Sure.
have a ton of questions, and more are coming in as I'm speaking right now. So let's get into it. So the first question I have here for you is, are there any new guidelines for the pediatric patients regarding UTI? So clinical symptoms and when to treat, as well as should we wait for culture or do urine test and treat following sensitivity?
So I am not aware of any pediatric guidelines from the Urological Association or any of the urological associations. And I do adult urology. So I don't know if the pediatric associations have some new guidelines or not. So I'm really not sure, but really not that I know of.
Okay. Next question is, why does incontinence increase the risk of UTIs?
So again, incontinence basically will cause, first of all, for some of that tissue, to not be as healthy. So if you have wet underwear or wet pad, um, it basically can irritate your tissue, um, again, promoting adhesion of bacteria. It can also be just a nidus for bacteria formation. It's warm, it's wet, it's like basically a good ground for multiplication of bacteria. And also it can cause just transfer of bacteria. Again, in whatever wet surface it is, it will cause transfer of bacteria.
Okay, thank you. Next question. So this is I guess a case. So they have a menopausal 60-year-old female with estrogen positive, progesterone positive breast cancer with atrophic vaginitis, stress incontinence, and frequent UTIs. What would you do?
So this is a patient, obviously, you get a little bit nervous about putting a patient like that on estrogen. So I would definitely just basically start with, again, hydration, possibly something like Replens, so like a vaginal moisturizer to just healthy up the tissue a little bit, prevent more trauma of the tissue, and then definitely a cranberry pill. So I would do, one Utiva daily, increase hydration, and make sure that they don't have vaginal dryness, and just treat that with a moisturizer.
Okay, thank you. Well, you already went through this. The question, well, partially, is D-Mannose helpful to prevent UTIs, which you mentioned, but then they're also asking about probiotics.
Yeah. So yeah, it's not my first go-to. So my first go-to is cranberry. And then if the patient still has UTIs, and especially if it's E. coli UTIs, yes, I do recommend D-Mannose for these patients. I kind of give them an option of trying different things. And I tend to mention that one first and say, hey, I would do that. Now, if you're going to do D-Mannose and cranberry, you want to take them at separate times of the day. So you want to do D-Mannose, let's say in the morning, cranberry in the evening. So you don't want to have them at the same time. And then as far as probiotics, the data on that is really mixed. So it's hard to recommend anything. If you're kind of desperate and you've tried a bunch of things, I think it's an option, maybe doing like a vaginal probiotic, like a high quality vaginal probiotic. Although oral probiotics have, some of them have been shown to possibly be a little bit helpful. So, I think if you're desperate, I would try probiotic. Otherwise, I would just use it as, if the patient is already taking an antibiotic, then I would, recommend doing a probiotic at the same time.
Thank you.
Mhm.
Is cranberry beneficial for recurrence in men?
Yeah, I use cranberry for recurrence in men. And actually, there was a study looking at like CAUTIs, catheter-associated infections, and most of those patients were male patients. And the study did show that cranberry helped decrease UTIs in those patients and decrease bacterial resistance in those patients. So I use it in both men and women.
Okay. For young females with a history of recurrent UTIs, do you prescribe macrodantin post-intercourse?
If they tell me that their infections are only associated with sex, so only at the time of sexual activity, otherwise they do not get an infection, then I would say, you can use a cranberry pill. You could try that as your sort of prophylaxis. If that doesn't work, then I would prescribe, some sort of postcoital, macrodantin or, anything postcoital.
Okay. And then just going back, another question just popped up, I guess in relation to cranberry use in men. What about prostatitis? Could Utiva Pack be used or maybe D-Mannose?
Yeah, I think so. I think cranberry is relatively harmless. I would definitely try it in men that have recurrent prostatitis, and I've done it before. You don't treat prostatitis with it, but for men that tend to get it, I think it's a very reasonable option.
Okay. Can you speak to the treatments or evaluation for patients with chronic Foley's and recurrent UTIs?
So similar evaluation, except that here, you really do have a reason why they're getting recurrent UTIs because they have a catheter in place. So even if it's not a true UTI, they may just be colonized with bacteria because of the catheter. But as far as the workup, I kind of do the same workup. I basically, check their UA, make sure there's no blood. If there's blood, I'll do a cystoscopy. And then I'll always do an ultrasound on these patients, because anybody that has an indwelling catheter can have a stone in their bladder. So I'll always do that. And then if all of that kind of checks out negative, then it's very good chance that the reason they're getting recurrent UTIs is because they basically have a foreign body in place.
Okay. What volume is significant for PVR?
So, we think this a significant volume, textbook significant volume is about 200 mLs. But if they're always retaining, 100, 150, that can be, again, a reason why somebody would get recurrent UTIs, but truly it's 200.
Okay. So the next question is, you made no reference to underwear. I think using thongs, all right. I think using thongs on a daily basis is increasing UTIs. Your opinion, please.
Yeah. So, this is not really research based, and that's why I didn't really mention it in here. It's not in our guidelines. There's really not a lot of data behind it, but I actually did mention it. I do tell patients that thongs can facilitate the transfer of bacteria, and I personally believe that. If you tend to get a lot of recurrent UTIs, I tell patients to maybe kind of watch that, to at least notice if you change your underwear practices, does it make a difference? So personally, I agree. I think that thongs can, if you're predisposed to UTIs, thongs can predispose you to UTIs. But it's not really in the research or in our data or in the guidelines. And a lot of physicians will disagree. So that's why I didn't really make much of that.
Yeah, that makes sense. And it's also, there's another question that's relatable. They were saying that there is no evidence for wiping from back to front versus
Right.
front to back. So I guess
agreed.
it's the same explanation, right?
The same explanation. There's really no data on this at all. But it's just one of those things for when patients come in and they're desperate because they're getting a lot of UTIs, I kind of gather up all of my thoughts and dish them out. So that's one of them.
Next question is, do you treat if showing greater than 100,000 but for organisms, or do you retest?
I'll usually retest. So if their UA is positive, I'll have them come in and do a catheterized specimen. Yeah.
Okay. So I am interested in the evidence supporting the use of antibiotic bladder irrigations for this indication. Some of our urologists are initiating patients on home aminoglycoside bladder irrigations. And then follow-up for this question is, which patients are ideal candidates for this therapy, and how does this medication get dispensed from your pharmacy?
So I've actually never had to do this. And I see a lot of patients with recurring UTIs. I don't think there's much data on this stuff because really, even at our meetings, at our urology meetings, I've really never heard people talk much about this. It's sort of anecdotal. Some people definitely do it, but there's not really any big data on this at all. So, but it's an interesting thing to look into because some people are really miserable and have a lot of UTIs and just can't get rid of them no matter what. I've never, like I said, I've never had to go that far, but I did have a woman one time who had a really inflamed looking bladder and kept on getting recurrent UTIs and just had like ulcerated looking bladder. And I did Elmeron installations in her, and that really helped her. Again, not really based on any data, just sort of trying to figure out what I could do for this patient. So I think, I think with the aminoglycosides, you would probably have to, you'd have to get it from the pharmacy. The patient would have to fill it in the pharmacy. But like I said, I've never really had to do it. So I don't know the logistics of it.
Okay, and then how about tobramycin as an irrigation?
Same thing.
Same thing.
I think maybe it may be useful to some patients. I agree, but I don't think there's really any robust data on this stuff or really any protocols at all.
Okay. Next question. Does phenazopyridine have a place in treatment?
Yeah, I think so what I tend to do is I like to get a culture on my patients. I don't start patient on antibiotics as soon as they call me and they tell me, I think I have a UTI, I don't start them on an antibiotic right away. And I don't do dips at all. I don't do urine dips. So what I'll do is I'll have them get a urine analysis and a culture, and that will take 48 hours to come back. And so in the meantime, I do tell these patients to take azo in order to be comfortable. Now, if I have a patient that I know super, super well, and I know that they're getting an infection every 3 months or, every 6 months, and it's always been culture positive, and these patients are super in tune with their body, then I will look at the UA and prescribe something. But for everybody else, I'll treat them with azo until I have a culture or at least a very convincing urine analysis.
Okay. For how long would you recommend to try Utiva Cranberry in primary care before referring to a urologist?
So I would give it 6 months. So I usually will see people back in 3 months, and like I said, I'll put people on Utiva. I'll have them back in 3 months. And after 3 months, I pretty much have a pretty good idea. They're either going to have no recurrence at all and they're doing great. Or they'll have less recurrences, or they're having just as many UTIs. And those patients tend to be difficult to treat. So those are the patients you start to really think, okay, like maybe we try D-Mannose, maybe we try methenamine, and you kind of go further and further. And I'll be honest, those patients it's not like one more agent and they're cured. It's usually like takes a lot of different trial and errors to really get them feeling better. But I would say not even 6 months. Like I would say 3 months, trial of Utiva for 3 months for sure. 3 to 6, and then urologist.
Okay.
Yeah.
And there was a follow-up question to the question you answered prior to this one. Azo, what did you mean by azo?
The pyra, blah, blah, blah. The question that you asked. We call it azo.
Azo, okay. It was phenazopyridine.
Yep,
AKA
phenazopyridine. Yep.
Okay.
I haven't had to say that in many, many years. So I'm like, I can't say it.
Yeah, it's a tongue twister.
Yep.
So do you treat a urine result with leukocytes only, or leukocytes POS and or nitrites POS?
So no, I actually, I don't really look at leukes or nitrites that much. I look at white cells. That's the first thing I look at, how many white cells are in the urine. So if there's I would say if there's about 20 or more, I start getting suspicious for a UTI. If it's like 5 or 10 white cells, it's probably not a UTI. And a lot of times 20 is not a UTI either. And if it's like 182 white cells or more, then it's like most likely a UTI basically, or that patient just has a really inflamed bladder and you want to find out what's going on. So that's that. So that's the biggest thing I look at. I look at the white cells because I don't really do the dips. So then I just look at the microscopy.
Okay. So next question, paraplegic who self-catheterizes intermittently but suffers recurrent UTIs despite being on daily prophylactic antibiotics. Any suggestions on further treatment? Image has been done, no stones. They suffer from frequent constipation and are also on laxatives.
Yeah, so again, those patients, methenamine, I use in a lot of the quadriplegic patients. I'll use methenamine. I'll try the cranberry in these patients. These patients are a little bit more difficult to manage. Now, if they're not symptomatic from their UTIs, then you don't need to treat them at all. You don't need to test them. You don't need to treat them. But if they're actually symptomatic, then I think I would just kind of, again, throw everything at them. I would try the methenamine, see how they do with that. I would definitely try cranberry. You could try D-Mannose on these patients. So you could try a lot of different things aside from just the antibiotic.
Okay. And then in regards to similar patient population, so quadriplegic, MS, ALS patients, what is the best approach for colonization for treatment?
So I tend to just, ignore the colonization. So unless this patient is going to have a procedure like a urological procedure or any procedure where the urine culture is important, I don't treat their UTIs and I don't look for the UTIs because they're probably going to be colonized. And then Yeah, that's basically it. Now, if they're having fever or some kind of sensory changes and they, and they think that's associated with their UTI because that's what it's traditionally been, they'll tell you, then I will treat that patient.
Okay. So I'm going to answer, or you're going to answer 4 more questions, and then we'll have to call it a night.
Sure.
So our next question is there any information about cranberry for prevention of infections with urostomy? Is that correct?
Uh,
Urostomy.
Oh, urostomy.
Yes.
So again, with urostomies, those patients are going to be chronically colonized. So a lot of times we really, unless it's very obvious that, that they have a UTI and whatever symptoms they have are coming from a UTI, a lot of times we kind of ignore positive cultures in these patients. Um, but as far as, cranberry prevention, I don't know any studies, regarding the adhesion of bacteria to, the intestinal tract, because bacteria is always present in the intestinal tract. So I don't know if cranberry will help, but we also don't know if these patients have true infections. So I don't know. It's worth trying if you think they're really truly having real, UTIs.
Okay. Is it safe to keep using vaginal estrogen for as long as needed, and what is your recommended dose?
So in order to keep my slideshow shorter, I actually took that slide out. But so what I typically tell patients is to start with 1 gram of, let's say, vaginal estrogen cream, so estrase cream. So you start with 1 gram daily and you do it for 2 weeks, every single day. And then you do it twice a week after that forever. And it is safe to use forever. Because again, we don't think it really gets absorbed in the body. It has not been shown to be associated with any cancers, anything like that. And so it is safe to use, and you basically want to do about 1 gram twice a week forever after you get the patient up to, up to a certain level by using it daily. And then the suppositories are the same. So like Vagifem suppositories, 10 micrograms, you want to do them twice a week as well, just the same exact way. So you either do it every day for 2 weeks and then twice a week after that. And the ring is once in 3 months. So you put it in for 3 months and then you exchange it in 3 months.
Okay, thank you.
Mhm.
Are these guidelines the same for long-term care patients? Would you treat them the same as you do in your clinic?
So these guidelines, it's funny because these guidelines really are for uncomplicated UTI patients, which are premenopausal women, that have no medical issues, et cetera. But then the guidelines actually talk about menopausal women. And so it's funny because they say it's for uncomplicated UTI patients, but then they are also for complicated UTI patients. So yes, I use these guidelines for all of my patients, literally all of them, complicated and uncomplicated patients. And my sort of workup and protocol is the same because it's not like we have all this great data for the different populations. We have only one set of data essentially for everybody. And so yeah, I use these guidelines for all of my patients, and I have pretty good success actually with treating recurrent UTI patients. So, I feel like the protocol works pretty well.
Awesome, thank you. And then our final question, I've been told true hematuria is positive erythrocytes seen on microscopic urinalysis. Chemical UA positive RBC does not count as true hematuria. Is this correct?
So if you dip the urine and you get blood positive, like +2 blood or +3 blood, you're right, that is not true hematuria. Now, if you actually look at the microscopy and you see RBCs, so erythrocytes, 3 or more, that is microscopic hematuria. That is true hematuria. So that's correct. And so for those patients, if they have a UTI and they have microscopic hematuria at the same time, so 3 or more RBCs and a UTI at the same time, I will recheck their urine to make sure the microscopic hematuria is gone. If it is not gone, if it's still there, they need a hematuria workup. So they need a cystoscopy, they need imaging, they need a hematuria workup. Yeah.
Okay, great. All right. Well, thank you so much, Dr. Barbalat, for joining us this evening. Thank you to
Sure.
everybody for all these wonderful questions. I wish we could keep going, but at
Great
some point we
question.
have to stop.
Yeah. All right.
But yeah, thank you so much for joining us.
Sure. Thank you. It was a pleasure.
Thanks, Dr. Barbalat.
Bye.